But really, research is kind of like poking around, it's like finding out stuff. And I think that's really served me well in my approach to research, which is not that it's this big scary thing that you need R01 funding for. It's just asking questions and figuring out the answers.
Hello, and welcome to the Art of Emergency Nursing podcast. This is where we share stories for inspiration, entertainment, and encouragement, because we all know emergency nurses have the best stories. Now here's your host, Kevin McFarland.
Chances are, if you've done any research in emergency nursing, you've run across my next guest's name. Or maybe you've been at an ENA conference and happened to see her speak. That's always a good time and always worth going to. My next guest has been an emergency nurse for over 20 years. She's been an educator. She's a nursing thought leader. In her professional life, she is the director of the Institute for Emergency Nursing Research for the ENA. You're going to enjoy this episode with my friend and hero, Dr. Lisa Wolf.
Okay, so I'm Lisa Wolf, and I'm been an emergency nurse for 20-something years. It was once I got into nursing school, it was the only thing I wanted to do, because it turns out labor and delivery is just not really a good place for me.
That's probably a good story.
Right? A little self-knowledge there.
Yeah.
And so I have been a staff nurse and a charge nurse and an assistant manager and an educator and a researcher and an academic. And right now, my main gig is being the director of research at the ENA and working in a local emergency department here in Western Mass as a staff nurse.
Nice.
Yeah.
I like to start these off with a favorite quote. What is a favorite quote for you?
So this comes from a surgeon who was working on the surgical ICU where I was teaching one year, and he looked at his resident and was like, "All right, man, here's the thing. Know your shit so you can focus on your patient." And that's kind of what has guided my career. Like, you don't want to be learning while you're taking care of somebody. Like, you got to know your stuff cold so you can not worry about what you know and what you don't know and focus totally on your patient.
Quote. It's a great quote.
Isn't it?
I love that. And it's so true.
Yeah, it just cuts to everything, right? Like, so the modified version of that is, nursing is a caring profession, so care enough to do your homework.
Is that what you tell your nursing students?
That's what I tell my students.
Or do you tell them know your shit? You probably tell them both.
So in class, I tell them to care enough to do their homework. In clinical,
Gotcha,
I tell them to know their shit.
What's something about you that your coworkers may not know?
That my area of expertise is actually ethics.
Okay.
And not like, I'm pretty good clinically. I'm really good clinically, but like my passion in nursing is like ethics and theory. It's all the geeky stuff.
Yeah. That's awesome.
Yeah.
How'd you get your start in nursing? Like, why nursing? You mentioned that once you did it, you knew that you wanted to be an emergency room nurse, and that was what you were going to do. Why nursing?
Yeah. So I was a smart kid, growing up in the 70s and 80s. And so in my understanding of the world, smart girls became doctors. So I was like, okay, I'm going to grow up and be a doctor. And everybody was like, yeah, great idea. So when I was about 14, I was part of a sort of a branch of the Boy Scouts called the Explorers. And so this was a pre-med group. And I was, the only girl in it because it was the 80s. And so we go to the big trauma center, Nassau County Medical Center on Long Island, where I grew up. And so I'm following this doctor around. And it occurs to me, like, he's not actually talking to the patients at all. Like, there's no relational component to this interaction at all. It's like he walks in. That's when they had the charts at the end of the bed, hanging off the end of the bed.
Uh-huh.
So he'd walk in. We rode our dinosaurs into the room where the paper charts were hanging on the end of the bed. And he looks at the chart and kind of peers over it for a second at the patient, like says a couple of things and walks out. And I'm like, this sucks. I don't want to be a doctor. This is terrible. So I kind of let that go and decided, all right, what the hell, I'll be an English major. So I go to college. I'm an English major, an anthropology major. I go to grad school. I am I'm a playwright. Maybe people don't know that about me. I have a Master of Fine Arts in playwriting.
Really?
And as you can see, I was wildly successful at that. So
wildly.
Wildly. So it did help in how fast I can write. I'll tell you that, though.
That's probably true.
So I'm now, like, I don't know, 26, 27. I'm languishing as an administrative assistant. I'm done being smarter than the people I work for. And so I'm working with this architecture firm that builds hospitals. And it turns out there's a nursing school, like, up the street. I'm like, okay, this is awesome. So I also find out this is sort of the era of the beginning of direct entry master's programs, right? So I figure I've got an undergraduate degree from Amherst College. I've got a master's degree. Like, I'll be able to get into one of these programs, no problem. So I apply to Yale, I apply to MGH, I apply to, like, one other one. And at this point, they're taking 4 people a year.
Wow.
So I don't get into any of them. And so I decided, like, okay, time to get practical. I'm going to the diploma program up the street. And so I did. So I went to St. Elizabeth's Hospital School of Nursing. And I think that nursing for me became really important. I was working in women's health, actually. So let me just back up a little bit. So I'm languishing as an administrative assistant, but I'm also working in a reproductive healthcare clinic in Boston.
Okay.
And so what I found, so we're dealing with people who are there to end their pregnancies for whatever reason. And what I saw in the nurses that I had not anticipated was exactly that relational piece that I found missing in the doctor-patient interaction that I saw. Right?
What a place where that couldn't be more critical.
Right. No kidding. So not only were these nurses, like, really clinically adept, right? They really knew what they were doing, but they were also unbelievably compassionate and non-judgmental and met people where they were and gave them the information they needed and supported them, like, all this stuff. And I was like, I want to be that. I want to do that.
That's awesome.
So that's where I was kind of looking, really in the women's health space, right? So the clinic that I initially started working in was a place that had, both an abortion clinic and birth control availability, gynecology. But on the other side of the building was a home for pregnant and parenting teenagers, right? So there was this idea that there's a continuum of care that addressed people, the same people, at different points in their lives.
Huh.
And so it was a fantastic introduction to, like, lifespan nursing, really.
Yeah, I bet.
It was amazing. It was great, and so, okay, I got it shot at a few times back in the 80s, but, I was, I'm like, Jesus, are we doing this again? So,
oh, Lord.
Yeah.
Wow.
So this translates really interestingly in the current, like, partnership work that I'm doing with AOEN. And I'm doing with, reproductive justice and all this stuff that has a really huge overlap in the emergency department.
Yeah.
So it all circles back. It's really cool.
That's cool.
Yeah.
Huh. So why ER? What was the transition?
So I go to nursing school, and thanks for bringing me back to that. So I go to nursing school, and I'm so excited about my labor and delivery rotation. I'm like, yeah, I want to be a midwife. I want to do this whole thing. I go to labor and delivery, and I'm like, why is this taking so long? Forever. Right?
Like, can we move this along?
Can we move this along? Like, why is this taking 12 hours? Like, I did not see that coming. So I realized that my threshold for patience was really inappropriately short for labor and delivery. So I was like, I guess I'm not going to do this. And then I did sort of an ICU ER semester.
Okay.
And I was like, holy cow, this is it. You know, when you find the thing, it was the thing.
That's awesome.
Yeah. But still, I was like, wow, I am. And I tell people this story, and they're like, really? You wanted to be a midwife? Are you kidding me? You'd be terrible at that. I'm like, I know. That's
like,
why I didn't do it.
That's funny. I remember the first time I stepped into an emergency department, and I my first role in the ER was as a tech, and I remember my first day being a tech in the ER and the cool stuff I got to see and the cool stuff I got to do, and I just remember thinking to myself, I found my people. Like, this is my people. Mm-hmm. This is what I do. This is who I am. And I remember being like, this is cool. Like, I never felt that anywhere else. I never felt as like I didn't know these people, but I know them. I got them. They're me. I'm them. We get each other.
Yeah.
And I was like, that's cool. This is what I'm meant to do.
Yeah. Well, you know, it was the same sort of understanding of the nature of like life, death, and existence.
Yeah, absolutely. The first day, my first day in the emergency department, I'm standing there basking in all the glory that is me at the nurse's station, thinking what a stud I am for being a tech in their ER, right? And next thing you know, I see a woman butt naked running down the hall, and I was like, "Oh, people." I'm like,
"Hey, look at that!"
Wait, what is that? And the charge nurse looks at me and goes, "Well, go get her." And I was like, okay. It was over. It was over then. I was like, I'll get to chase old naked people. What more can you want?
Right. Super. It puts everything in perspective, right? I feel like I'm a much more grounded human now.
I think I am too.
Yeah. Like, life is unpredictable. Eat dessert first. Right?
Ain't that the truth? That's cool. So how did you get into research? Well, how did that start?
So I was, this is back in New York, right? So I had like 7 different jobs at this one hospital. I kind of like was a serial monogamist with my job, you know. So I was being a night educator in this hospital. It's 450 bed hospital, level 2 trauma. And so I'm responsible for walking around at night and fixing stuff, basically like looking for trouble and putting out fires. This is the best job ever. I would do that job forever. So because I covered the house, but I was also the trauma coordinator, which, 15 mumble years ago, again, still on paper, right? So I'm walking around, and part of my job was to take all the trauma charts and review them, right? So medical records would pull all the charts with the ICD-9 codes for trauma, and I'd look through them and see if they were actually traumas, right?
Yeah.
So, like, was this a pathological fracture rather than, was this femur fracture pathological or traumatic, right? So those kinds of things, kind of sorting them out. So I'm looking through these files, and back in the day, we would write on the triage sheet where the patient was placed, right? So whatever the bed number was, in the hall, under the clock, by the pole, where the patient was placed. And so in this case, I started seeing, now these are trauma charts, right? So I'm seeing patients who are going to the ICU, but they're coming to the ICU from fast track or the hallway or under the clock. And I'm like, why are these people with these head bleeds? You know, what is this, right? So I pull all the charts together, and I'm like, okay. So I start writing down all the demographics. It's so rudimentary. It's like, you know, with crayons, really. I'm writing down all the demographics of the people, and I'm finding that they are like all over 55. They're all anticoagulated. They all have the presenting complaint was like a head lack or a bruise, you know, like a bump. And they all had Glasgow Coma scores of 15. Right?
Okay.
So for us, you could send somebody with a head bump, a head injury, to fast track for, you know, sutures or whatever if their GCS was 15. So we have all these people who present as totally intact, but they all end up going to the ICU for, you know, subdurals.
Yeah.
So I pull this together and I start looking at the literature, such as it is, and you know, and I find that this is kind of a thing. So I write it up, I submit it to Jen, it gets published, and I start presenting this, like, to our EMS people and to our nurses, and so that was kind of really the first research study that I did. You know, I'm describing this constellation of things, and then we, you know, it changed practice at our hospital.
That's awesome.
Which was awesome. Yeah. So we stopped. You know, if people fit that criteria, even if they came like jogging in, we would scan them.
Yeah.
So so that was kind of cool. So that was, I want to say 2005, 2006, maybe. So I was in the middle of a master's program. Like, I didn't even have a master's degree in nursing yet.
Really?
But really, so research is kind of like poking around, you know? It's like finding out stuff. And I think that's really served me well in my approach to research, which is not that it's this big, scary thing that you need R01 funding for. It's just asking questions and figuring out the answers.
Yeah.
And so that's, you know, it's a very practical approach, even though I do a lot of stuff with theory. You know, it's all still has very practical applications. And to me, that's useful research. You know, that's not like research for its own sake.
Yeah.
It's like real problem solving stuff.
Like, let's figure this stuff out.
Right. And I think that, and that's really why I continue a clinical practice.
That's cool. That's really cool. Holy cow. And so that was your first article you ever published?
No, the first one I published was on my orientation program for new people new to the emergency department.
Oh, wow.
So this starts this very crazy trajectory, right? So I'm pregnant with James, right? My 14-year-old.
Okay.
And I'm working as an assistant manager at my hospital. And for whatever reason, my bosses don't like the fact that I'm pregnant. So they're giving me this crappy, you know, year-end review. So I decide I'm really not going to take this lying down. So I drag my big old belly up to the senior VP of nursing. And I'm like, hey, listen, here's the story, right? Here's what's going on. And I said, and, you know, we're seeing all these problems in the ER and whatever. And she goes, well, you know, what we really need is an emergency department educator. And I was like, how interesting, because I'm in a master's program for nursing education. So like with that, I was now the educator, and I was given the assignment of orienting. Let's see, there was a huge nursing shortage. This is probably 2004 or 2005. There's this huge nursing shortage in New York, so they're bringing over nurses from the Philippines and India and all this stuff.
Oh yeah.
So they're like, okay, we have 4 or 5 nurses coming from the Philippines in, you know, July 1st, and we would very much like you to develop an orientation program for them. And I was like, well, do they have any ER experience? No, they don't. They're all like med surge or labor and delivery nurses.
Okay.
So I was like, okay. So this is where like theory is so helpful though, right? So I'm in this master's program and I'm going through like the whole Benner thing. And I'm like, okay, the from novice to expert stuff. And I'm like, okay, so how do we teach to proficiency? Like what if we kind of taught people to the level we want them to practice at, but just support them a lot, right?
Yeah.
So I was trying to figure out like, okay, what is the really important pieces of emergency nursing? Like, what do people have to be really good at? And it's like identifying and listening and communicating rather than they have to be able to start an IV and they have to, be able to do all these technical things. Like any idiot can learn how to start an IV or put a catheter in. It's how do you communicate the need for that? How do you really do a good assessment, right? So I came up with this program that was kind of thinking backwards, like thinking from symptomatic presentation to diagnosis, right? Because I knew that people who were not emergency nurses were thinking the other way, like here's the diagnosis and then everything else spills out.
Yeah.
So I developed this program that really focused on symptomatic presentation and the appropriate questions that you had to ask people to get the right answer, right? Not giving them the answer or giving them the data, like what data do you need? So that was like 2 weeks. So the program, I shaved it down considerably, but in its first iteration, there was like a week, like solid 40 hours of didactic and discussion and classroom. And then there was a bunch of time for simulation, so like practice stuff and a skills lab and, that kind of stuff. And then I treated them, I put them to orient in the department. First, I had them go to different departments, right? Like spend a day in OB, spend a day in ICU, right? Do that kind of stuff. And then when I had them working in the department, I ran them like a clinical group because what I found, like these were tough old New York nurses, right? And they had no time for people who had no idea what they were doing.
Yeah.
So I'm like, okay, how do we circumvent this part? The part of orientation that kills people because the nurses are old and mean, right?
Yep.
How do we fix this?
Yep.
So I oriented them like a nursing school clinical group.
Wow.
So I had 4 of them. And so the first day we each took one bed, right? Like whatever comes through this bed belongs to you. And so I basically took over a section of the ER with the primary nurse kind of backing me up. And we did that for a couple of days. And then I moved them up to 2 beds. And then I moved them up to 3 beds and then 4 beds over the course of about 8 weeks.
Wow.
Right? So it was slow. It was labor intensive. But by the time they were ready to then go to their shift of hire, I could not only tell their preceptors, like, this is what they're good at. This is what they're not good at. Like, these are the things that you need to work with them on. But they also had a lot more insight into what they were good at and what they were not good at.
Yeah.
Right? So they did that for like another 4 to 6 weeks. And then when they came off orientation, I kind of floated to their shifts to provide support.
That's cool.
So super labor intensive, but, and I did it like 4 or 5 times. I ended up orienting, I want to say like 30 nurses.
Wow.
Over the course of 2 years. And none of them left. Like the retention rate was 100%.
That's crazy.
Right. So, I go up to Massachusetts and I kind of do the same thing. But, I run into some more logistical problems, right? So I start with new grads for the first time, but I was like, okay, new grads are great because they don't have any bad habits, right? They don't have any bad positive habits. So anyway, so I did that and I wrote that up, right, to to Jen, and so I'm in my house, and I get a phone call, and it's Gail Lenahan, who's the editor at that point of the Jen.
Uh-huh.
And she's like, so listen, I want to talk to you about this article. And I was like, oh my God, like I couldn't even talk. I was so starstruck. I was like, oh my God, Gail Lenahan's on the phone with me. And so she walked me through it. So anyway, that's the first thing I published. But after that, I was like, oh, this isn't so hard. I'll just write it and send it in, and write it and send it in. So I published a bunch of stuff initially. And then as I entered my doctoral work, I realized that the stuff I was writing about, a lot of it was triage stuff.
Yeah.
It was really all part of the same problem, right? Like I was just nibbling the elephant at different parts. And the work that I did at Boston College really put all those things together in a theoretical way that made sense for the bigger problem, right? So it's like, oh, it's not just that people suck at triage or they have trouble with these particular populations. It's that the person themselves and the environment in which they're functioning interact to make clinical decision-making good or sucky.
Yeah.
So that's kind of guided the rest of the work that I've done.
That's cool.
Yeah.
How exciting.
It's really fun.
I bet. What's your favorite article you've written?
Wow. The next one.
The next one. The one that's almost done.
Right. I'm writing up the weed study, which is going to be awesome.
Oh, that's cool.
Yeah, I think actually the one that's had the biggest impact is the theoretical description of workplace bullying.
That was going to be my next question. Is which one do you think had the biggest impact? So,
yeah, I think that one has had the biggest impact because we published it in an international journal, and I presented this in Holland, in the Netherlands, in October to an international group, and they were all like, "Oh yeah, we need to get in on this." So
that's awesome.
The best part of a theory is that, especially a mid-range theory, is that it gives you a roadmap, right? It describes the phenomenon, but it also gives really clear opportunities for intervention, right? So we're not just describing the problem, we're showing you where and what kind of interventions make sense. So the next step then is like, okay, so now we're going to test the model for theoretical coherence, right? Just to make sure we're right. But then we can start saying, okay, so here's an intervention for charge nurses we're going to try, and here's an intervention, for staffing that we're going to try, that kind of stuff.
Have any emergency departments fully implemented the stuff that you laid out?
No,
Okay.
not yet. Well, I mean, it's only been published for like a year.
Okay.
I think people don't read as much as they should, to be honest with you.
Absolutely.
Right? Like people just don't read. So people say, oh, I'm having this problem. Like, well, very interesting. We, especially stuff like staffing, right? I think the staffing work that we've done potentially could have the biggest impact.
If people read it.
But people either, read it and they're like, oh, this is great. Or they read it and go, well, we could never do this.
Yeah.
Right? Because healthcare is now a business. And so a lot of this stuff that we're saying is like, this is one of those things where you have to spend money on staffing to save money on lawsuits and, improve your patient outcomes and that kind of stuff.
Absolutely.
So actually the new, we're reissuing the staffing guidelines in a way that is more contextual.
Okay.
Right. So what happened is when we issued the staffing guidelines in like 2013, this comes out of this fantastic statistical model, right? That is like math. It's the math, right? So we're pretty sure that this is actually a valid model, and so people would, but the LMS or the online offering was really just like the formula, right? Here's how we develop the formula, and it's about the math, and people don't care about that, right?
Yeah.
So what I would get though is a call at least once a week with somebody like, hey, I want to talk to you about the staffing guidelines, and I'm like, okay, it's great math, right? And they're like, yeah, I can't give this number to my administration.
Huh.
I'm like, why not? They're like, it's too high. I'm like, well, what's your wait time? 8 hours. Do you feel like you're understaffed? Oh my God, yes. Okay, then the number isn't wrong.
Yeah.
It's kind of you don't have enough people.
Yeah.
So this reiteration, this new iteration is really focused on why appropriate staffing is so important and why coming as close to this number as you possibly can is going to improve things, like not just for your patient outcomes, but also for your nursing outcomes, right? Because exhausted people are crabby. They're mean to each other.
Right. That
impacts patient care, right? Like the whole thing with workplace bullying really, or workplace violence in that type really comes down to staffing.
Huh.
Hired people are mean.
I've never really thought about it that way.
Right? They're overwhelmed, they're exhausted, they're burnt out, and they don't have a scrap of kindness for each other.
Wow. I've never really thought about it that way.
Yeah.
But that makes a lot of sense. I mean, you see it when the emergency department I worked in for a really long time, we were just busy all the time. It just felt like a fire hose all the time.
Right.
And there were sometimes that people just weren't nice. And
right.
like a patient never, ever, ever complains about technique. Like they're never like, Kevin's really terrible at starting IVs. Kevin's really terrible at getting the Foley in. It's always, Kevin just made me feel terrible.
Mm-hmm. Right.
And you're like it's never like nobody complains about skill. Nobody cares about your skill. They just care about how you talk to them. And,
right.
And getting people to understand that is, you're like, yeah. I remember the worst thing one of the worst things that happened when I was there. I'm in there with this patient. This patient's, was like, hey, I got a complaint. And I was like, okay, what's your complaint? She's like, people come in here. They don't tell me who they are. They just come in here and start doing stuff to me like I'm a piece of meat. And I'm like trying to hold in my eye roll, like, oh God, okay, sure. And she had a pretty good nurse. But as I'm sitting there talking to her, I'm sitting there in the stool, and I'm the charge nurse that day. I'm sitting there in the stool, and I'm having a conversation with her. Literally, one of the techs walks in and goes, hey, we need to draw more blood. Puts a tourniquet on her and just starts going to town. And I'm sitting there going, and she's just looking at me like, do you see what I mean?
Yeah.
It's like, oh.
So think about this, right? Like, we've been doing this a long time. I don't know about you. I can't be in 10 places at once.
No.
I can't take care of 10 people in the way that they deserve to be taken care of.
Not in the way they deserve to be taken care of.
Right? And that's sort of, so what we found, okay, so this is the really cool thing, right? So we started doing this work on moral distress, right? So me and Paul Clark and Michael Moon and Kathy Zawadzki were all like, yeah, we love moral distress. We gotta look at that. So we started talking to people, and really that's the bottom line. I cannot take care of people in the way they deserve to be taken care of, right? It's not, and that's what puts this, it's a disciplinary obligation, right? Like my job as a nurse is to take care of people in a respectful, dignified, competent way, right? Now, the fact that I have 10 patients to take care of means I cannot do that. And therefore, when this thing came out in 2015, I did a whole bunch of radio interviews, and people kept asking, like, well, how is this different than people just being fed up and tired? I'm like, because their concern is that their patients are not getting what they deserve. It is a disciplinary, ethical issue. However, other issues along that, so now we start looking at other things, right? We start looking at fatigue. And this very surprising finding in our qualitative investigation of fatigue is that people are like, this makes people mean. This is a cause, ultimately, a cause and an effect of workplace bullying. People are tired because other people are mean to them. Like, it's a psychological weight.
Yeah.
And then they turn around and they are mean to other people, right? So then we're like, oh, this is really interesting. So then we start looking at workplace bullying as a phenomenon that is derived directly from the conditions under which people are working.
Huh.
And yeah, so now it becomes not just you, Kevin, are nasty man, right? It becomes this system produces people who are unable at all times to be kind to each other. So we got some systemic problems to deal with, as well as individuals, as well as individual problems. So the work
system's
that we've
stacked
done,
against you. The system's stacked against you.
Absolutely. So what we're really looking at is in the sort of research trajectory, right? Like when you do a research study, if you do it well, you should get not the answer, you should get a lot more questions. And so in that sense, the work that we're doing with the IENR is wildly successful. And we're like, hey, what about that's really interesting? We should look at that too.
Yeah. Yeah, it's every time I think about doing research, I think of a question, then I think of like 100 more questions.
Sure, but you got to start somewhere, right?
But you got to start
somewhere. You don't have to answer all the questions. You just have to answer the first question.
Yeah.
And then you know what the next question is, right? So
absolutely.
It's like little Reese's Pieces. You lay them down in a line, you pick them up and eat them.
Follow the trail. Follow the trail.
Follow the trail. But, the other thing is that research is a really, it's a very defiant act in a way, which is probably why I like it so much.
I've never thought of it that way.
Because you keep asking questions. You keep asking the questions, and people would rather you not ask the questions.
Yes, that's a good point. I mean,
yeah.
I guess as a researcher, your job is to ask the hard question.
Yeah. And put the answers out there so that people can't pretend like that they don't know the answers now.
Huh. Never really thought of it that way.
Yeah.
It's interesting. So your role is Chief Defiance Officer, right?
Yes, at AOEN, I am the chief troublemaker.
This has been a really fun episode with Dr. Lisa Wolf. Hearing from her and hearing about her research has been absolutely fascinating. I'm curious your thoughts. Do you think fatigue and overwork contribute to workplace bullying? Have you noticed that in your practice? Leave me a message on Facebook and let me know your thoughts. I'm going to put the full title of the article in the show notes so that you can take a look for it, and I want you to read that article. If you're having a hard time finding it, message me, and I'll see if I can help you. We're going to continue this episode with a part 2, so don't forget to subscribe, and I'll talk to you next week.
Thanks for listening to the Art of Emergency Nursing podcast. Make sure to subscribe to the podcast and follow us on Facebook.